So I've got the slides for you, so we can actually just firstly.
All right,
you're
going to be doing the slides.
I've got your slides for you.
Well, we've had to do a little bit of jiggery pokery here, ladies and gentlemen, because of the vagaries of IT. There we go. Overactive bladder in women.
Let me just get back to the webinar. Sorry, we should all be like completely perfect on Zoom today, but we're not. Due to the okay. Let's go back to this one, and we can share our screen, Pete.
There we go.
There we go, and I think you can see us.
The screen.
Straight back to this one.
Yeah.
And I'm going to just do this.
Make it full screen. There we go. Pete. That's full screen.
Is that good enough? And Pete's just going to go down. You can go down like this. You can just go down with this.
Steve, you just go down for me because I'll just be talking and you'll be going down. Now, ladies and gentlemen, so it's a great honor and privilege to be with us this afternoon. I'd like to start with our first slide. Remember,
this is the first slide. I don't know where the rest of the talk is, Pete. Sorry about that.
That is the first slide that you share.
I don't know where the rest of that is, Pete. Just give us a minute. Sorry, guys. We are going to.
Well, Steve, this is a topic we haven't broached for many, many years.
Yeah, it is, and it's something that we, it's actually such a
important topic because it's so common, and also there's been great advances recently. So we thought it was apposite that we could start and reopen this topic.
Do you see a lot of OAB, Pete?
Huge amounts, Steve. I mean, 60% of women have OAB as they become postmenopausal. So it is a huge problem. And for that reason, I think we should have an up-to-date approach and have all the tools at our fingertips as to see what we can use.
Chris might have the slides a little bit more on his, there we go. Let's go, Pete. There we go, Pete. There we go. Oh, no, it's wrong one. Sorry.
Wrong one, Steve. So, ladies and gentlemen, I'd like to start then with a disclaimer. The first disclaimer is this, while Steve's looking for the disclaimers slide, is we're only going to be speaking about overactive bladder and urinary urge incontinence in women, not in men.
There we go, Pete. There are your slides.
And can you give
all these? Yeah, is our screen now shared, Chris?
Yeah, the screen is shared.
Okay, there we go. Okay, there we go. Pete, there's just this.
Thank you,
despite
Steve.
our best attempts at getting ready for this before we started, we are now back, and there we go, Pete. I can't make it any bigger than that, Pete.
All right, can I have the second slide, Steve?
There we go. There we go. You can just move them like that.
I'll toggle it down. So yeah, so we're not going to be speaking about overactive bladder in men or overactive bladder in children or other forms of urinary incontinence. We concentrating then on OAB or overactive bladder. We're also excluding, in this case, transgender and gender expansive individuals or diverse gender individuals with overactive bladder. So there we go. Urinary incontinence has undergone all sorts of new definitions in the recent past, Steve. In the past, it was the involuntary leakage of urine, which is a hygienic problem. Now that rider has been removed. So urinary incontinence is defined nowadays as the involuntary leakage of urine. Doesn't have to be a hygienic problem. Some people being more fastidious than others. So if you have involuntary leakage of urine in women, you have urinary incontinence. And as I said, 60% of adult women have some form of urinary incontinence. Menopausal women, it's enormously prevalent. And for that reason, I think we should have a good approach. The type of incontinence depends on your population. It's dependent on the woman's age, her parity, genetic and familial factors. Now, urinary urge incontinence, or as we call it, urge urinary incontinence, is leakage associated with urgency. And it's used, this term, interchangeably with the overactive bladder syndrome, which consists of 3 important symptoms. OAB is urgency, nocturia, and frequency.
Okay.
Thank you. So urgency urinary incontinence, which is now called UUI, or urgency urinary incontinence, is women that experience the urge to avoid immediately preceding or accompanied by leakage. And the OAB, or overactive bladder, as I say, used interchangeably is urgency with or without leakage, often accompanied by nocturia and frequency. So you've got the nocturia and the frequency, and some people call it OAB wet if the woman does have the overactive bladder with incontinence, OAB wet. The impact of health on a woman's life is enormous, because not only does it cause depression, anxiety, isolation feelings, and disability, so she has reduced quality of life, it also might be important in sexual function, because coital incontinence occurs in at least 10% of these cases, and that does negatively influence sexual function. The morbidity caused by urinary incontinence is considerable. I'm sure everybody has seen older women over here that have dermatitis, that have inflammation, that have infection, and that is occasioned by the chronic and constant exposure to urine. Not only do they have that dermatitis, but they are more likely to have falls and fractures, and the costs are also phenomenal. 10% of nursing home admissions are due to urinary incontinence. That means that if a woman has urinary incontinence and she cannot be nursed at home, there's a high chance that she'll end up in a nursing home or facility of that nature.
Peter, you're going to be talking about these older women with incontinence, because it can be difficult. You know, they are to a certain extent, when you see a patient sitting in a wheelchair in your office, you know they're going to cut. They are invariably brought by very caring family members, you know, it can be a challenge. You know, they're often quite unwell, they immobile, they, you know, sometimes take a few minutes to get them onto the bed and off the bed, and you know. Are you going to be talking a little bit about
I am,
patients?
Steve.
Okay.
I certainly am.
Yeah.
And also, incidentally, if anybody wishes to interrupt with questions, interruption is quite acceptable. I'm a married man, so I'm used to interruptions. So just interrupt if you feel free to do so.
But I think we might, from a practical point of view, take some of the questions at the end, because we can't really see.
So there are no interruptions.
So for the first time, no interruptions.
Thanks, Steve. Now let's look at the etiology of urgency urinary incontinence. Most common, ladies and gentlemen, it's idiopathic. We always wax lyrical as the GAG layer and the effects thereof. We've spoken about transmissions, neurotransmissions, but under the circumstance of limited time we find ourselves in this afternoon, we're going to have to go with the catch-all of idiopathic causes of urgency urinary incontinence. But the detrusor overactivity leads to uninhibited contractions during filling. Many women have this and they don't even have incontinence. So although it might be normal, in many cases, it leads to detrusor overactivity and the urgency. Now, how do you define urgency? Well, that's the requirement to void that is difficult to defer. So if she has that, she can defer it, then it's OAB dry. If she is unable to defer the detrusor overactivity and there's a detrusor contraction, which leads to incontinence, that's OAB wet. Also, nowadays, we've discovered an altered bladder microbiome. We've spoken about this before. And the bladder microbiome is terribly important, and this can be altered for different reasons. Neurological abnormalities might lead to urgency urinary incontinence, and these have to be excluded. The other factors are, for example, vaginal atrophy, urinary tract infections, medications, fluid intake, and diabetes. Now, let's just look over there. OAB might be caused then by atrophy of the vagina, and you're well advised to examine the woman and see if she does have this and treat it. I know that many texts say you can treat this on spec without examination, Steve. I don't, this sticks in my throat that you can see a woman and treat her before you've made a proper diagnosis and excluded other forms of anatomical defects. I do think you should examine her. Urinary tract infections is terribly easy to exclude. Medications, when I do the clinic at Groote Hospital, you'd be surprised how many women are on Rudac or other diuretics. And there's no other form of medication more inclined to cause overactive bladder than a diuretic, especially taken at night. So see if you can change the Rudac for something different. Another thing that causes coughing and incontinence is ACE inhibitors. We're often told that a woman should have 6 to 8 glasses of water a day. And if you go down to Canal Walk or the waterfront, you'll see what we call the sippy Evian syndrome. It's a woman walking around with bottles of water, sipping at them as if they're in the Namib Desert. And Linda Cardozo is coined the sippy Evian syndrome. So unless a woman is for any particular medical reason, drinking all that fluid, 4 or 5 glasses of fluid in total is more than enough. And one of the biggest and main causes of the neurologic abnormalities is diabetes mellitus. Not only does that cause a huge intake of water, it results in a sugary solution of urine which irritates the lining no end. So that has to be done. There are 3 types of urinary incontinence in the new classification. It's stress incontinence, urgency, overflow, and the 4th type is mixed, a combination of the above. In the first consultation, you take the history and get the general habits and history of the patient, because if she's on medications, these have to be tailored not to cause diuresis and coughing. Surgical history must be taken, of course, gynecological and obstetrical history, and you have to check if she's had any prolapse surgery in the past. If she's a smoker, this has to stop, because smoking can cause urinary incontinence. Interestingly enough, Steve, if a woman uses alcohol or coffee, this is not a predisposer of overactive bladder, although tea is, because of the theophylline content that a tea has. So if a woman wishes to carry on with her coffee, by all means, or even use decaf, rooibos doesn't have caffeine. So that is something that she can alternatively indulge in. The other causes in the history is woman has had a stroke in the past, or Parkinsonism, hydrocephalus, and you can't examine a woman and notice she had hydrocephalus without further special investigations. And the diabetic autonomic neuropathy is a killer for bladder function. Of course, bladder cancer and fistula and radiation are other causes of irritation in the bladder. And mode of delivery is an interesting one, because although cesarean section is somewhat protective, it's not completely protective. So if she's had vaginal deliveries, she can carry on having vaginal deliveries, because the Caesar is not going to be protective. And it's a fallacy to think that you can prevent all prolapse and incontinence by having cesarean deliveries.
What's in that picture, Pete?
Yeah, Steve, this is a very sad case at Curtis Care Hospital. The woman had had a vaginal delivery 3 months before, and she had such severe incontinence occasioned by a vaginal delivery. I said to her, "Excuse me, can you explain what's happening? There's your pantaloons and there's a nappy." She says, "I first have to change my own nappy before changing the baby's nappies." Yeah. And that to me was a poignant picture. It showed just how much of an issue this can become.
Yeah, it's a terrible, terrible problem. As you say, it affects the patients, and the pads are expensive. That's often one of the first complaints, is that, if you buy a packet of Tina pads, it's about 110 Rand for 10. And if they
these adult diapers,
yeah, so Tinas are very good absorbent pads, and by the time they get onto those, it can be anything between 100 and 120 Rand. And if you're running through 5 or 6 a day, that's already 60 Rand.
That's why it's such an expensive exercise.
So yeah, you can't buy cigarettes if you have to spend money on that. So
unless you smoke Caesars like you do. Now, the first consultation, ladies and gentlemen, you can't compartmentalize. You can't put things in silos. And that's why I think that these women should be examined. And that's why I think that they should be seen and examined before therapy is begun. So you can't say, well, look, let's just have a go at giving you some treatment and see what happens. Because there are other forms of genital problems like the incontinence, the prolapse, fecal incontinence, and other forms of pelvic floor dysfunction. It all fits together as a constellation, a smorgasbord of symptoms. So you actually have to address everything together. If she has dyspareunia, this might be incontinence, this might be caused by the leakage. Pain has to be addressed, bladder pain, of course, the bowel symptoms as well. It all has to be looked at in a constellation. When you do the evaluation, one very, very good thing to do is a quality of life assessment. And the woman can fill out this while she's sitting in your waiting room. And the quality of life and bladder diary are things that can be mailed to her, emailed to her, even prior to consultations. It has 2 functions. Number 1, it helps her focus. What exactly is the problem? What exactly is causing all the symptoms? Is this a big problem, or is it not a big problem? What is the degree of bothersomeness that this causes? And she fills out her bladder diary and brings it along. Not only can you see exactly what her symptoms are, Steve, but you can also see the degree of bothersomeness And before you initiate therapy, it's good to know a baseline. And when you've initiated therapy, this can be reviewed after 3 months, and you can see if there's a change and the degree of change in her symptoms. So there are many good reasons to have a quality of a life assessment and a bladder diary prior to consultation and prior to initiation of therapy. Now let's have a look here, ladies and gentlemen. Steve was doing all the changes, and I just want to see where he's been doing the changes. Steve, can you just show me the next slide? I don't know.
Got a call from the ward. So
From the ward.
yeah. Oh, sorry. Where's he gone now?
I don't know.
Have you been playing with this?
I didn't touch anything.
Sorry about that.
Yeah, there we go.
Oh, let's get. Where's it back? What was the other one? Sorry. Oh. This one. Repeat.
Okay, thanks, Steve.
Sorry about all this very bad technical management today.
There we go. That way, that's it.
Yeah.
So the first thing you do, Steve, after you've done the history, is a general examination. And obviously, the physical examination starts with the urine dipsticks. I don't think an MSU is required if the dipsticks is negative. And then a full and complete gynecological exam is mandatory for the reasons I've mentioned.
Pete, something just on this. Some people will say that you should think about a urine cytology, where some urologists do quite like urine cytology. I don't do it routinely, but if there is some suggestion that there might be some malignancy underlying, you don't want to go the full way in doing cystoscopies, etc. Something that is quite nice to add to your assessment, urine cytology, especially if the patient was a heavy smoker or something. You might want to do that. And it is just quite a nice screening tool that might protect you if there was something a little bit more serious happening there.
Yeah, but in the evaluation, I would say start with the simple things to begin with. We don't have to do imaging. So you just do a general clinical examination. As I've mentioned, use your eyes and ears, and you should be fine. And characterization of history is important because the patient will tell you if she's got overactive bladder because of the symptoms we've mentioned. And if that is the case, and you've done the examination, then we get to the therapy, which comes into play. If you do see the external genitalia atrophic, then it's important, I think, it's behoves you then to give a topical progesterone therapy, topical estrogen therapy. Now, the treatment. You start always with behavior modification, which means don't overdrink the tea, don't smoke, and you must have a proper eating pattern because obese women do have much, much more urinary incontinence, and that's not only stress incontinence, it's also overactive bladder symptoms. So it's important then to gain a normal BMI if that is at all possible. Then we get on to pharmacotherapy and then the procedures which you're going to tell us about. So pelvic floor exercises where we begin. We've mentioned that it's good for both forms, that's stress and urge incontinence, and it should be tried for probably between 6 and 12 weeks with behavioral therapy to see if this is going to help. In addition to which, you would correct the modifiable factors like giving estrogen. The medication must be adjusted and the fluids must be reduced if the woman is overhydrating. All therapies, alternate therapies like hypnotherapy and acupuncture have been tried. The literature which I assess shows that although these might not be useful in controlled trials, they certainly would be harmless. And if a woman feels that hypnotherapy or acupuncture is of some use, by all means, they're to continue.
On that point, Pete, Marina Scuti, who's a urogynecologist down at Constantiaberg, when he was a registrar, performed an acupuncture study with me there, and we assessed patients with refractory overactive bladder that were not responding to the medications, and I think we had about 20 patients who had acupuncture, and it actually worked quite well in a selected group of patients. Obviously, it was hard to exclude the placebo factor, but yeah, certainly did work. So no, I don't think I don't use it, but I mean, it is something that
If a woman
has
finds
worked,
use,
yeah,
by all means,
yeah,
to do it.
yeah.
In terms of the medication, Steve, there's two big groups. There's the antimuscarinics, which are also called the anticholinergics. They're the cheaper versions. Then there's the beta-3 adrenergics. And if your pockets are deep, you can go for those. If you're working at critical care hospital, the formulary only allows the anticholinergics. Now, it might take several weeks to optimize, and they may be used singly or in combination of these two groups. So let's look then to start with the anticholinergics. These agents block the muscarinic receptors and so reduce the stimulation of the detrusor by acetylcholine, and the contractions then are reduced. There's no question they do work. They reduce the urgency, they increase bladder capacity, they're commonly available, they're cheap, the generics available, long-acting forms are available, and the big problem, of course, is the side effects. So although they work and they're effective, their use is limited by the fact that side effects do mitigate against their continuous use after a year. You'd find that a large number of women have suspended the use of antimuscarinics because of the side effects.
Yeah. So you do say they're cheap, but I mean, you're really only talking about the oxybutynin, the ditropan. I mean, the rest of them are actually still quite expensive, aren't they, Pete?
They are. We're coming to the list in a minute.
There we go.
There's 7 of them available. Now, whether they're available at the moment or not, they come and go. That's the strange things. Sometimes you can get trospium, sometimes you can't. So it just depends on your local dischem as to what they're stocking. Yeah, they are. Darafenicin, solifenacin.
I don't think darafenicin is available in South Africa anymore.
No, some of them aren't. For example, piperivin is available in the East. And oxybutynin, as you mentioned, is available as an instantaneous release and an extended release. Available, it still is, and as a generic form and also as a long-acting form. There's the solifenacin, which is Visicare, tolterodine, trospium, propivarine. Now, they all have similar efficacy, but their choice depends on what's available, what you can get hold of, and the patient's comorbidities. Next slide, Steve.
Are you going to be talking in a bit more detail about that?
I am.
Okay, good.
I certainly am. Now, as a general rule, there's a class effect in these antimuscarinics of side effects, Steve. You start at the top and you work your way down, because side effects are aplenty. They cause, if you start at the top, there's cognitive defects, cognitive impairment, and long-term use may even precipitate dementia. So it's not always a good idea in older people that have cognitive impairment to use the antimuscarinics. They do cause drowsiness and blurred vision. Then you go down, and they cause dry mouth. Now, what do you do if a woman's got such a dry mouth she can hardly swallow? Now, you can say, all right, you must have yogurt and have some yogurt and some water available. But again, that's using other forms of therapy to compensate for the side effects of your agents. And the tachyarrhythmias is also a huge problem. So if a woman does have tachyarrhythmias, I wouldn't give her antimuscarinics unless I had to. Myasthenia gravis, and the one that we all know about, is narrow angle glaucoma. We don't usually test for it, but if they have got it, you certainly can't use antimuscarinics in this group. So what you would do is you would start with the, go back a bit, sorry, Steve. You would start with the lowest dose of these agents. Now, they all got different doses, so get hold of the lowest dose and start slowly. And generally, after several weeks, you'd increase your dose until you get optimal use. And you might have to compensate by trying different types and different formulations to find something that works.
Now, Pete, just on this list, I mean, I think for me, the solifenacin, which is the VCK, is the only one that really I try. And you got the 2.5 and the 10 milligrams. I haven't used the trusitol in a long time. Is it actually available, which is tolterodine?
Yeah, it is.
But a lot of people like Urispaz, which is propivarine, actually.
Propivarine.
Yeah.
Well, Urispaz is meant to have a local anesthetic action as well.
Yeah, and a lot of GPs use it. So many of my patients who end up here, but it's a tedious dose, and it will indeed have quite a lot of side effects as well. So
it's extremely popular, and it's one of the best sellers of all the agents that are available.
But solifenacin has now got a generic called Finance, which is cheaper. I mean, sulfenacin itself, the VCK was about almost 500 rand a month.
Not cheap, not
And
cheap.
I don't really know, is fesoterodine available in South Africa?
I don't know that, Steve.
Yeah, but I mean, my first line certainly isn't any of the anticholinergics. But I mean, if you're going for the oxybutynin, it's like 30 rand a month. It's very cheap.
Not that expensive, and it is available on the formulary at Rescue. That's why they use it.
And we mustn't forget about it. You know, I had a patient here that was I was trying all sorts of things with Betmega, and then I went on to VCK, and then she actually ended up immigrating to London, and she sent me an email to say, "Have you heard of a drug called oxybutynin? It's working very well for me."
They have it on the
So you said in private practice, you're trying all sorts of expensive drugs, and you don't actually end up using it. You know?
Just before we go off that slide, do you know the difference between Lyrica and Lyronel?
Well, I mean, the Lyronel is the oxybutynin extended release.
Exactly.
Yeah.
And that is if they have side effects which are intractable, try the extended release. It's more expensive, but
it's a nice flexible dosing as well. I mean, you can go from the 5, 10, and the 20 milligram. But
that's right. So it's worth knowing it. Steve, if you go to the antimuscarinics, the anticholinergics, the beta-3 adrenergic agonists, mirabegron. Now people say, no, you're always mentioning these names and you're mentioning Betmega. Just remember, we're not being sponsored at all by anybody here, Steve. So we can mention names.
No, I mean, this is a completely clinical talk. I mean, we've got no sponsors.
Astellas doesn't give us any money for punting mirabegron. And this stimulates the receptors for smooth muscle relaxation. And in that way, it does improve then bladder function, more volume and less urgency. The big problem, of course, there is hypertension. So if a woman is hypertensive, you've got to control it first before trying even the 25 milligram version of the Betmega. And the side effects, then, it can cause hypertension. So that has to be checked in the course of time. Begin with 25 milligrams and, if necessary, bump it up. Refractory OAB, you can use it with sulfenacin together and see if you can get better effects. Highly effective action is the mirabegrons. Fewer side effects, we've mentioned, than the anticholinergics, better tolerated, but there still is a discontinuation after a year. 10% of people have discontinued.
Well, I think it's more than that, unfortunately, Peter. I suppose depending on what population you use, the anticholinergics after a year, only about 10 to 20% of patients are taking it. But this has actually got a better
profile.
Yeah, so it's about 40% of patients are still taking it, and that's due to the efficacy being better. And then obviously you're going to talk about, is a generic now available of the Betmega?
Is there? I did not.
Yes. Yeah.
Oh, that's wonderful.
So this was also one of the more expensive drugs, also marketed by Astellas, like the VCK. But it's called Urton, URTON, and seems to work as well as Betmega. So, and I think that's why Astellas is really pulled out for more marketing.
Oh, good heavens. So, also, it's quite long acting. So if you were going to church on a Sunday morning, you could take it beforehand and it would last. Or if you're going dancing on a Saturday night, you could take it as required. Because if there is expense, you could use it as required.
But just from a purely practical point of view, the Urton or mirabegron is the only one I really start off with. And I've been given a script for VCK or any of the anticholinergics for quite a long time. But maybe it's just a idea of the profile of the patients I see. Yeah.
Don't forget the reversible causes. And if a woman does have the reversible causes, constipation is a reversible cause. So that is something worth looking at. Overflow incontinence has got those symptoms you see over there. And the problem with overflow incontinence, it's very easy to diagnose. Go to the next slide, Steve, and you'll see there. You just check a post-void residual. Now, there's no universally accepted. What volume do you use as a post-void residual accepted volume, Steve? If a woman voids, how much would you, there's not really, but what would you actually accept? My cutoff is 50 or 100, depending on her age.
Depends on the clinical scenario. I did a TVT on a patient last week who came from London for this TVT, but she's running around the residual of about 100 now. So she wants to go back to London. Is that an acceptable residual or not? So, where do you draw the line? I don't think it's time to go and loosen the TVT, or cut it. But, but I think you certainly are going to get an increase in the risk of recurrent urinary tract infections, anything above 30. And there is data on that. So, so I mean, it's, but I think the bottom line is to always check the residual. It's very important, and that can indeed affect the patient's outcomes. And, you might be dealing with something else they do have residual. There might be a multiple, they might have MS.
They might have
there could-
diabetes.
Yeah, there might be something else there. So that's why it's very important. And we've all got ultrasound machines in our office, and this little formula is quite a good way to just check what volume you've got there.
More than 50, you must teach her. Maybe a physio would help you. Yeah, I mean, you've got a very good physio, as do I. They'd be able to help avoid completely. Double voiding is an old French trick, and that is something that can help people to empty and so reduce your risk of recurrent UTIs. So, Steve, tell us a bit about Botox.
Yeah, so I'm just going to open my talk. It's right here. So let's get that. Yeah, so we there will be a little bit of repetition, but I thought we'd just emphasize a few things.
No, we do have to have some repetition.
So just again, don't forget about the differential. We all know number 3 at the bottom here is idiopathic, but there are quite a few things that can cause OAB type symptoms in patients, and you just need to run through that in your head. We've certainly seen these things, and you might be need to be careful, especially if the patient isn't responding to your treatment.
Yeah, Steve, I agree. If the patient is not responding, you have to go further. I understand the accepted wisdom that you can treat on spec, but I still can't get myself to treat on spec without examining a woman.
Absolutely. So, you do have run through this in your head. I mean, we're always grappling whether this is stress incontinence, and it can be tempting to go and do a TVT in someone who's leaking anyway, but you do need to be careful. Don't forget about bladder pain syndrome. We'll talk a little bit about that. Prolapse. And so there's just a little list of things to run through. And Pete's already looked at this. And a point that I always make is having a look at the posterior compartment. Bladder diary is very useful, and I wanted to just show this. This is a patient of mine. You can actually see she passed a large volume at night. And this patient ended up being sent to a physician to investigate her for potential diabetes insipidus. So that's something you really need to think about. This is a little drug that, I say little because these tablets are very small, but I've actually, in a very specific group of patients, had good success, and that is using this desmopressin, which is DDAVP. And if a patient's got a very specific symptoms of nocturia, it's really worth trying this. It basically reduces the production of urine at night, and you can start at 0.1, you can go all up to 0.4 milligrams. And you do need to be careful. Check the patient's blood pressure and urine E before you start it, and then advise the patient to not take it if she gets diarrhea, vomiting, anything that is going to disrupt her fluid balance. But I've had patients go down from nocturia 4 or 5 times down to once or twice, and they do like it. So this isn't something that you might want to think about in some patients.
Is it expensive, Steve?
It's cheap, and it's available at Credit Scare, believe it or not. We've already spoken about that. I did just want to mention something about ultrasound, because it is a very useful part of my whole assessment of these patients. What I really look for is this bladder wall thickness, detrusor wall thickness. We use the so I'm bouncing up and down here, I know, but basically I do the bladder ultrasound this way, using the normal baby ultrasound probe that you would normally do your fetal assessment, and put a glove over the end there, and this is the view you get. So it's quite easy to see the urethra, and I would advise you to practice this in your office, because it is a very useful way of doing a pelvic floor assessment. I personally don't think you need a fancy ultrasound machine with very expensive software. I've basically got a 20-year-old ultrasound machine in one of my offices, and I use that, and it really does work very well. So you can actually see there's the bladder neck, there's the urethra, symphysis, and the anal canal. So with practice, you eventually get quite good at seeing what you want to see here. But I really just want to show you the usefulness of this in assessments of patients with overactive bladder, where you can actually check the detrusor wall thickness, and you can actually see this detrusor wall here, and anything more than 5 millimeters would suggest that this patient does have a significant amount of overactive bladder.
Steve, do you have to have a certain volume of urine?
No. This is Peter Dietz's work that he's done a lot of, and this is the technique that he used and has been using for years. And he actually even uses it in an empty bladder. But most patients do at least have some urine in the bladder. And I just ask them to get onto the bed without emptying the bladder first. And you can normally see it quite nicely. So I think it's a very useful thing, especially in a patient who might have a lot of stress incontinence and overactive bladder mixed. You're not really sure where you are. If you do an ultrasound and you see a really thick detrusor wall of say 7 millimeters, then you know, well, this is maybe something that you need to be careful of. You don't want to go and do TVT immediately in that patient. But you can actually see bladder wall thickness is there and measured to be 10 millimeters. And that really would say, well, be careful. Yeah, this patient probably has quite a significant component of an overactive bladder.
What is your cutoff, Steve?
5 millimeters.
5 millimeters.
Yeah. Urodynamics are useful, but not essential for any of my patients before they have any of the treatment forms. So, and we're jumping straight into thinking about all the surgical options. But really just being mindful of the fact that there is about an overlap of about almost a third patients having both urge and stress incontinence symptoms. And it's an interesting discussion as to where you should go first. But if I see stress incontinence, I'm often quite tempted to go ahead and treat the stress incontinence first, and then you might want to treat the urgency. But every patient will walk out of here with at least a prescription for a Betmega or Erton if they've got urgency symptoms, even if they have been booked for a sling, if they've got significant urgency symptoms at the same time. Well, how do you approach the whole issue of mixed incontinence, Pete?
Well, Steve, I'm an old-fashioned person that starts with the OAB.
Yeah.
That's the urge urinary incontinence with the Betmega, and I'll just evaluate her improvement. Hopefully, there is an improvement before doing it, and if she has both, then I think perhaps urodynamics is warranted. But under general circumstance, I mentioned before, if a woman only has OAB symptoms, you don't need imaging and you don't need urodynamics.
No, I don't think so. All right, so I did want to mention this other very tricky condition called the bladder pain syndrome. It's got various names. We still like to call it interstitial cystitis. In these patients, this is what you'll see when you do a cystoscopy. You can see this very inflamed bladder. The etiology and cause of this still remains unclear, but in these patients, the symptom of pain is very prominent, but they do often present with urgency, incontinence, frequency, and nocturia. But if there's a component of pain, you might want to indeed think about doing a cystoscopy on them. But just so you know, we do start them on a regime of oral medications. And I think you would do well to give them a trial of starting with a tricyclic antidepressant. Something that has made a big difference to these patients in the last 5 years in my practice is this mast cell stabilizer called Montelukast. You'll all know it very well if you are aware of the asthmatic treatments these days. But this is Montelukast, and there's all sorts of generics, the Singulair, Montair, but it has Foxair.
Fox.
Yeah, I think Foxair is also Montelukast. I don't know them very well, but I give the patient, I just write up Montelukast 10 milligrams a day, and in fact, it's worked very well in a lot of patients, and it's worth trying patients on this as a first line actually in my practice.
And that's for interstitial cystitis and bladder pain.
Yeah, but remember, so a lot of these patients will come to you with symptoms of both overactive bladder and some bladder pain, and it might be worth just trying them on that before you do anything else. If you are quite suspicious that it is an interstitial cystitis picture rather.
See, to go back, what's this? Omeprazole.
We have used omeprazole in the past because remember it's an H2 agonist.
Yeah.
And we know that there's a large histaminic or histamine component to the whole overactive bladder. And if you actually look at the biopsies of these patients, you'll find that there is quite a strong component of a histamine and a sort of an allergic type reaction as well. So but yeah, I just wanted to mention this quickly because it's I'm seeing a lot of patients with interstitial cystitis, and it is quite good if we try and you can often get some symptomatic relief in these patients with some of these medications. And again, this is we often then move on to some installations, and these all sorts of there've been a few that have been tried, But well, this talk isn't really about that, but there you can actually see the types of things that we have been using. And then just a quick thing about prolapse. What about surgery for overactive bladder? Etienne Hen was a consultant at in Bloemfontein. He did his PhD on the basically the rectus seal posterior repair, and he found that in patients who had significant overactive bladder symptoms, there were good improvements in their symptoms if they had a posterior repair. Now, I'm not saying.
How do you explain that, Steve?
Well, I think, you know, you're getting that irritation of the bladder neck with that rectus seal. So, I certainly think that when I do my ultrasound in these patients, you'll often do rectal and you'll see that bladder neck being irritated by the rectus seal. So, if it's a patient who's really not getting any improvement from your Betmiga or your VC care, and they do have a significant posterior compartment prolapse, I think it is worth at least offering them a repair, with the understanding that it might indeed still not give the effect. But I think if you are going to be going to do some more advanced treatments on these patients, I think it certainly is worth doing a very simple posterior repair in these patients. Then you can actually see how these symptoms did improve in the study of Etienne Hen. I don't really think the video is going to work, but there you can actually see how oh, this is just a perennial ultrasound that I'm doing. And there's the bladder, there's the urethra, and my finger's in the rectum at this point. And you can actually see how the rectum is actually, the bladder neck is actually being compressed by this rectus seal. And you need to be suspicious of this in a patient who says when they stand up, they suddenly get this urgency and they might leak. And that's often the reason for that. And it's quite a funny symptom to try and interpret in patients. Don't forget other more complicated things like a diverticulum, and you can actually see this is another ultrasound of a patient. There's the urethra, and you can actually see she had a diverticulum. So do an ultrasound. You will certainly pick a big diverticulum up if you do regular ultrasound in these patients, and that would be then something that you could either repair yourself or refer on to urologist to fix.
Won't you feel a diverticulum, Steve? Do you have to?
Well, sometimes you do your vaginal examination, and sometimes that's just that urethra can feel quite thick anyway, isn't it, Pete?
And sore.
Yeah,
and
but
and
this is very easy to do, Pete. I mean, you just put your perennial probe on there and you'll see it. I mean, even with you might even see it with your transvaginal probe, but this is very easy to do. And it's, you know, you really do get a lot of information from it. So this is the sort of patient that you would then now think about going on to a more elaborate treatment option. And I've already said that, and this is where you're now starting to think about your more complicated treatment options. And in my practice, the two main things that I do is I do sacral nerve stimulation and I do Botox. Those are the two things that I now offer the patients if they've had no response to an anticholinergic or Betmiga. They don't have a residual, suggesting that they're voiding well and that there's not a more complicated neurological issue. They don't have stress incontinence, which requires treatment. It's not interstitial cystitis and it's not cancer. So these are the very important things that I will run through in my mind. There's obviously some other considerations, but these are the things that you would then start to think about, and then moving on to a more elaborate treatment option. And here we go. This is just summarizes a lot of what Peter's already told us. So you're going from your lifestyle modifications onto your containment products, pharmacotherapy, and then you start thinking about Botox and your sacral nerve stimulation. Now, it would be tempting to, at this point, say, well, you know, that's not something that, you know, we're really that interested in. But you do need to bear with me because both of these have been very effective. And I always say some of my happiest patients that I see in my practice are the patients who've had either Botox, but indeed, especially the neuromodulation. And to the point of where we, even on my desk today, I've got the battery from the neuromodulation. So we do speak to a lot of patients about it. It's something that really does work. And it's, you know, as I've been doing these for the last 5 or 6 years, I've been offering more and more patients the sacral nerve stimulation because they are very happy often taking it. But let's talk firstly about Botox because this is a lot easier. It's a lot more simple. And we all know that botulinum toxin is used extensively in many pathologies. They've been using it for headaches. As a patient of mine yesterday was talking about having a migraine treated with Botox. They treat excessive sweating. If you find they're treating axillary sweating, all the way down to the neurological problems. And it was indeed first proposed by the doctors who were managing patients with spinal cord injuries who had all these contractures, and they were treating these contractures with Botox. And then they decided, well, why don't we try it in the bladder? And that was Bridget Schuch in the early 2000s who was doing that in Geneva. And she started to do Botox into the bladder. And you can actually see how it gets done. Basically 20 injections of Botox using this long needle. We use 100 units as a standard form of treatment, diluted into 10 mils of saline cystoscopically, and you inject it into the bladder, and that's the main. And you can actually see the way that we do it. So these got the 10 mil syringe with the needle going through this the cystoscope, and indeed a very easy treatment option. And this was actually the study that was done in the UK that was really the landmark.
Is this the study you did, Steve?
No, this is not the study. This was a multi-center study in the UK that allowed Allergan to indeed register Botox as a standard treatment form for up until this paper was published, I think in like only about maybe 5 or 6 or maybe a little bit longer ago. It was used off-label. But this study actually enabled Allergan to register Botox as a official treatment option for overactive bladder. And this was actually a placebo-controlled trial, and you can actually see the significant improvements in the patients with severe urgency incontinence, and very much better compared to placebo. So we use 100 units as a standard, and it lasts for 9 months. In my practice, I've got patients who now onto their 9th or 10th Botox already. And indeed, Dudley Robinson, who we all know quite well, he's vice president of Ayuga, and he's been to South Africa many times. He's Linda Cardozo's colleague, or the late Linda Cardozo's colleague. He presented some data from King's at a conference recently, and they've had some patients who've had 21 Botox injections. So the Botox is effective. It works well in a large number of patients. I think in my practice, I've probably got a lower threshold of going onto something like Botox because I know it works so well. The medical aids do cover it. And just the unfortunate thing is that it only lasts 9 months. But once you've had a good response to Botox in a patient, they'll call my office when it starts wearing off, and they'll go straight back onto a list for another dose of Botox. They'll come in, it takes me 5 minutes to give. They go out very quickly, they back to their normal lives. And as I say, the medical aids do cover it. There is a risk of voiding dysfunction. I mean, this study, it's probably less than, it was about 8 or 9%, but in my practices, I think it's less than 1%. So that's Botox. And then something I really like is the sacral nerve stimulation. It's very effective, and these are sometimes the happiest patients in my practice. Just a quick one to show you how it works. No, sorry, wrong one. Yeah, didn't put any pictures. Yeah, but basically, it works by placing, I don't know if you can see this picture, but this is the battery, and it gets inserted into the patient's buttock. And there's a little electrode that goes into the sacral nerve, S root 3. We put it under X-ray guidance with fluoroscopy, and we are able to find sacral nerve root 3 or 4. We know we're in sacral nerve root 3 by seeing a bellows on the buttocks versus, and you also see a foot flexion. If you're in sacral nerve root 4, you only see a buttocks sort of bellows, we call it. And we are then able to know that we're in the right place, and then the patient will have a trial phase, and then eventually we'll go and put in the permanent sacral nerve stimulator. But it is a very effective treatment form. And if you've got a patient who's not responding to the not responding to your medications, you can then offer them either the Botox or you can offer them the sacral nerve stimulation.
Would you always start with the Botox, Steve?
No, not at all. Botox, you have to really weigh up both options with the patients. I give them both options. I explain to them the advantages, the disadvantages of both of them. This battery for the Interstim lasts about 5 years. There is actually a 10-year one that will be coming in the next few months. And that means the patient is able to not worry about any further treatment for almost 10 years once by the time. But this, as I said, this 5-year battery is very nice. You know, if you think about it, after 9 months, patients then get a return of symptoms if they've had Botox, and they have to come back for another treatment. Whereas once they've got the Interstim in, it works really well. So, and it's, as I say, it's effective. I think a lot of my younger patients go for the Interstim, and I put one in a 17-year-old patient about 3 months ago, and she had actually a very good result. So overactive bladder doesn't only affect older people, it affects younger people as well, and it is something to really think about. And just some of the data on the Interstim, you can actually see that it really does give very effective reduction in overactive bladder symptoms, almost 90 to 92% improvement in many symptoms, and great improvements in quality of life. And there has been a randomized trial comparing both Botox to Interstim, and they are basically very similar in efficacy. So I think you would do well to give patients both options and trying to decide what they want to do. Some patients just aren't interested in going around for the faff of this Interstim, and they'll rather just go for something simple like the Botox, which is great. But I mean, as I say, if the patients want to go for Interstim, it is covered by most medical aids. It does require quite a lot of motivation, and it does require some motivation from the patient to have a more elaborate treatment option. But once they've got the Interstim in and it's working, they're often very happy patients. So there we go. Just one last thing. The patients in whom I would really recommend an Interstim is those patients who've got double incontinence. And if the patients have got both fecal and urinary incontinence, this is a great treatment option. So that's why I've ended with such a disgusting slide. And there you can actually see how it improves, you know, in both the double incontinence patient, fecal and urgency incontinence.
Steve, it's been a wonderful presentation. Thank you very much indeed for all your input. And I look forward to next week. We're going to be talking about urinary tract infections repeatedly, are we?
Yes, we'll talk a little bit about, so we've got a sort of almost a little bit of a double header. We're going to be talking about recurrent urinary tract infections next week. We'll actually, a little bit of a primer. We'll be talking about this new vaccine that we have for recurrent urinary tract infections. Again, we got not paid by anyone, but this is something that has been really effective in my patients. And so if you want to know more about the vaccine for recurrent UTIs, you can log on next week and we'll talk about that in more detail.
Thank you. And a special thank you to Chris. It's been wonderful. And to the hundreds of people that logged on, I'm sorry that we had those technical problems at the beginning, but certainly we look forward to seeing you the same time, same place, same platform next week.
There was one question.
All right. Who's?
Anyway,
Betmiga is Mirabegron. That's correct.
That's right.
Yeah, Betmiga and Mirabegron is the same thing.
Good.
Muscarinic.
Thank you. All right. Thanks so much, Pete. Yeah, thanks to Pete as well for a great talk, and we'll see you all next week.
Thank you
very much.
Good night and safe home.
Thank you very much.